Hi, it's David Liew here, reporting from Barcelona for EULAR 2025. And right now, I want to tell you a little bit about one of the really interesting RA-ILD abstracts. Now, I don't always present on RA-ILD, partially because often we've got people in the team who are have far more expertise in ILD than I do. But I was really excited by this abstract, and I think it is the kind of thing that might excite you too, even if you're not a specific ILD aficionado. And that's because I think the fundamental issue that I have with RA-ILD, that when a patient comes into my room, sometimes they are the one that really just accelerates and blows out their RA-ILD when they have it. And they go from 0 to 100 really quickly. And then sometimes it just sits there and doesn't really do anything, and it just stays static. And it's really hard for me to know which one is going to be which. And there are some broad measures, and I think we've seen a lot of progress in that space, but nothing really that's been able to bring them all together in a predictive tool. But that's what we've seen today from the South Koreans working with RheumNow's own Jeff Sparks on a predictive tool that's abstract 0p0329 at today's meeting. And so, in essence, they took 138 RA-ILD patients, saw how they progressed, tried to pick pick the ones that over the next 2.5 years had progressive disease, progressively fibrosing disease. And then they took some of those clinical features that we might actually have access to in clinic, UIP pattern, ILD extent, DLCO, ACPA, as well as the specific KL6, which is a biomarker specific to ILD. But knowing that's not always available, they did a model without it and with it. And even in the model without it, actually the performance was pretty good. The AUC was 0.75. So this is actually not bad. I'm sure that with bigger numbers, these predictive tools will get better. They put the algorithm up on screen. It's one that it's got face validity, it's logical, it makes sense. So this would be really exciting if this washes out well in the external validation. Because what I'd really like to be able to do with RA-ILD patients is know whether this is a high risk for progression, a medium risk for progression, a low risk for progression. And those high risk ones, I'm going to be doing things a lot more intensely, both in terms of monitoring and potentially in terms of therapies, than I would do for the low risk ones. If we can start to stratify that out, knowing what we know already about individual risk factors, combining them into a predictive tool, and if that's something that we can use in the clinic room, then I mean, I really think it's the kind of thing where we can hopefully treat the right RA-ILD with the right types of therapy, take the serious stuff seriously, and the stuff that won't progress, we can relax a little bit. For plenty more about RA, and I mean plenty more, you know where to go. Rheumatoid.com.